Without further ado, I'll start off with our first case from Bengaluru. Over to Dr. Rashmi.
Yeah. So this is a 2-year-old child who had come to me for a second opinion, and the child had global developmental delay. So he had variable tone. So sometimes he was hypertonic, sometimes he was hypotonic. He had variable tone. I think for 2 years old, he was just about able to sit independently. He was not able to stand or walk, though now he's slightly improving with physiotherapy. He was also noted to have mild vision impairment, which was thought to be cerebral visual impairment. He was a firstborn of non-consanguineous marriage, and there was a history of neonatal jaundice, but the levels were not very high, and the treatment was just with phototherapy.
Okay. The scan done at what time? What age, Dr. Rashmi?
So the scan was done
couple of months back.
I think they were done just recently, because I asked them to get it done in Clarity, and
I think couple of months back, so around 1 year,
couple of months back. Yeah. Very recently only the scan was done.
Okay. All right. So we have the T2 axils and planar axils here on the slide, and you can appreciate there is some prominence of the frontal subarachnoid spaces. But the main findings are the predominant, which are in the globus pallidus. You can see that there are symmetrical hyperintensities in the bilateral globus pallidus. You can see that there is reduction in the volume of the globus pallidus. Coming down to the brainstem and the posterior fossa structures, I cannot appreciate any significant abnormalities. Some degree of cortical volume loss in the frontal regions or widen the subarachnoid spaces with these globus pallidus hyperintensities and volume loss. Corresponding images not as prominent as we have seen on the T2s, but you can see that there are some flare hyperintensities in the globus pallidus. No corresponding diffusion changes in the central regions, no corresponding SWA changes such as mineralization or blooming or hemorrhage. T1s did not demonstrate any significant findings. There was no malformations. So other than the globus pallidi changes and some degree of frontal abnormality, I couldn't appreciate any other findings. On SAG, possible some reduction in the volume of the midbrain out here, but the corpus callosum is normal, and the rest of the posterior fossa structures demonstrate normal volume. So if we concentrate on the globus pallidus related changes, these are the different imaging differentials. So to start off with, kernicterus can also be present in methylmalonic acidemias, but child is in chronic stage. It is not an acute onset or not a catabolic stressor. So the changes are in the chronic stage, and any of the differentials can be a possibility. So imaging-wise, these were differentials which were considered a possibility of kernicterus. So I think Dr. Rashmi has already mentioned that the jaundice levels were not severely elevated. We did not do a spectroscopy to check for creatine deficiency disorders. But yeah, these are the imaging differentials which we are working on. I'll open the case if anyone has any further suggestions now.
SSIDH will have any markers on the MRS?
No, not on the MRS application. Only the creatine one will have. I mean, creatine deficiency. SSIDH, I mean, the globus pallidus and the midbrain abnormalities can be seen. Also, dentate nucleus changes. But SSIDH is a difference.
Okay. Sure. Because that midbrain atrophy is something quite striking.
I think, Dr. Nihaal, they came to you for second opinion, and you had reported it as changes consistent with kernicterus. So I wanted to know whether it's worthwhile doing a genetic test for this child. Do the other possibilities seem likely? Considering that there was not a history of exchange transfusion that the jaundice.
What about the hearing and the vertical upgaze movements for this child?
Vertical upgaze and all was not there. No movement abnormalities was there. Only the ophthalmologist had said, they see this pale fundi in cerebral visual impairment. That was there. Hearing was normal.
Because some cases we have seen which the jaundice was not very high documented at least, and then you have all the features of kernicterus in the child. So rarely it happens. But if there is a doubtful thing in the history that you should first child in the family.
Yeah, it's a first child of non-consanguineous marriage.
Okay. So probably worthwhile once doing, at least if there is absolutely no history with the midbrain atrophy is slightly unusual for kernicterus. Can we see that in the kernicterus as well, the midbrain atrophy?
Yeah, Dr. Lokesh, because the cerebral peduncles are usually involved, but over here the signal changes are not as what we usually see in connectors. They can be hyperintensities, but the midbrain glavitic changes can be seen.
So
And
Dr.
also the
Jain,
diffuse cortical atrophy is slightly more for the age.
Dr. Jain has
Yeah.
noticed LCAT. They saw a similar MRI picture with turned out to be LCAT.
Yeah, fatty acid oxidation can also have, yeah, those spectrum can also have these status changes.
Okay.
Only thing is the clinical handle, how strong is it for a, do they usually have hypoglycemia or ketotic hypoglycemia or something like
LCAT, usually they're present in the newborn period.
Yeah.
So they are quite sick in the newborn period only. That's my experience of LCAT.
Okay.
This one has been pretty stable, sort of a static encephalopathy, as if you want to call it. So this one has been pretty stable. But midbrain atrophy, you said, is not a feature of chronic stress. Is that right?
So midbrain involvement can be seen.
Midbrain involvement can be seen
Yeah.
in chronic stress.
Yeah.
Then,
in terms of signal changes, the cerebral peduncles usually have some abnormalities out there.
Yeah.
Any the TMS, was the TMS done? Newborn screening or TMS?
No, TMS was not done. So they had, see, the previous report before I asked Dr. Nihaal for a second opinion was that benign enlargement of subarachnoid spaces, which I think is unlikely. This is more like atrophy, no? That was a previous report from the radiologist with prominent VR spaces with very patchy area of temporal lobes, which again I think is there, right?
No. There's no patchy area. There is no prominent VR spaces.
So
I think the main findings are in the global studies. So
yeah.
Even the best.
So wait a second. Sorry, I was lying. The TMS is normal. Newborn screening normal. BERA shows a little bit of hearing loss. Thyroid function test normal. CPK was a little high, 427. Lactate creatinine was normal. And yeah, so this is the thing. And then vision impairment, as I said, the cerebral visual impairment, where they say a pale fundus and everything. So these are the results. Yeah. So TMS was normal. So with hearing loss, connectors is more likely, correct? You're thinking?
Yeah, I mean, yeah.
But it's a first child. If you have doubts, better to go for genetic screening, no?
Yeah, I think that's what Dr. Lokesh has mentioned.
Yeah. Yeah, I think that is what it is. Yeah, I got your thing. You have also said about the perivascular spaces, no, in your report, Dr. Nihaal. Prominent
I don't.
spaces.
But they are not of any significance. They don't add to the diagnosis.
They don't add to the diagnosis. Okay.
No, they don't add to the diagnosis. These are usually in the subcortical regions. The child is not completely myelinated yet. So these can be seen as part of the unmyelinated brain. But these are not those cystic perivascular spaces which can can point us towards another diagnosis. These are just the normal.
Normal perivascular.
I mean, they are. You can see them, but I wouldn't say that it helps in the diagnosis, at least on image.
Okay, sure. So I'll offer them genetic testing, just in case they're planning for future pregnancy or if they want to know. Otherwise, I'll say that most likely related to connectors if there is hearing loss.
Yeah.
Okay. Thank you so much for adding this to the discussion. Huh? Thank you.
Thanks, Dr. All right. Do you have the team from Trivandrum, Aarti or Dr. Kalpana? Okay, can't see them on the panelists. Lakshman, just make RTB as panelist.
Okay, sir.
Yeah.
Can you please repeat the name, sir?
It's in the chat. Dr. RTB.
Aarti, ma'am. Okay. Done, sir.
Okay. Aarti, are you on the panel? I mean, I can't see. Okay, maybe we'll go on to the next case. In the meanwhile, you can make her a panelist. Okay. All right. So we'll move on to our next case. This is actually not from a clinician. This was actually I put up this case. The parents, I think, may have joined the session. Child resides in the in USA, and they have sent these images for another opinion. So they just wanted to discuss on this panel. So this is a 16-month-old male child with developmental delay, had conductive hearing loss and myopathy diagnosed on ultrasound. The older sibling is a sister who is normal, no developmental concerns. So on the newborn screening, they had detected a deficiency of galactocerebrosidase, which raising a concern of Krabbe's disease. What they also found was the psychosine, which is supposed to be a marker, was normal. So based on that, the child was followed up and imaged. I'll show the imaging later on, but these are the genetic assessment for the child. They evaluated for Krabbe's disease, and as you can see, there was mentioned as homozygous pathogenic variants for Krabbe's. Newborn screening also demonstrated decreased galactocerebrosidase. Psychosine was also decreased. I'll show the imaging first, and then we can discuss the significance of the variants and what is to be followed. So thinking of Krabbe's disease, the child had 3 scans, one in the neonatal period, then the infantil period. This is the most latest scan around 14 months of age. What the main findings are in the posterior fossa and in the midline structures. You can see that the corpus callosum is hypoplastic, more along the mid and posterior segments. There is hypoplasia of the brainstem structures, particularly the pons. There's a slight groove over there in the ventral aspect, but you can see the significant reduction in the craniocaudal dimensions of the pons. On the axial sequences, again, reduced the volume of the brainstem structures, more in the pons. Cerebellum could not appreciate any hypoplasia or significant atrophy. The main findings, what we could find was the corpus callosum and the brainstem abnormality, predominantly in the pontine region. Supratentorially, there was some degree of volume loss in the frontal regions. The ventricles are slightly stick-like. There is persistent cavum septum pellucidum, but other than that, cannot appreciate any significant malformations in the supratentorial brain. T2s again demonstrate the similar changes which are seen on the axial T1 sections. The main findings are in the corpus callosum and the pons. Based on the imaging findings, we think of possible differentials of these Chart syndrome, pre-Chart syndrome, 5p deletion, DOX7 gene. If you look at the DOX7 related variants, some of the case reports have similar imaging findings seen in our case. You can see that there's some slight ventral groove over there. There's a significant pontine hypoplasia. Cerebellum is relatively normal. They can be associated with cerebral cysts. So these were the possibilities on imaging which we thought of. And since it doesn't match Krabbe's disease, they just wanted to know clinically what is the next steps and any variants of significance out here. The other 2 genes which they found was the LOXHT1, which is a gene for hearing loss, does not correlate with our case, and the SCYL2 is the gene for arthrogryposis and corpus callosum abnormalities, which this child does not have. So based on that, they wanted to know if any other things need to be done, any other considerations for this child.
Was this whole exome sequencing?
Whole exome sequencing, Dr. Lokesh, with I think whole genome also. Chromosomal microarray also was done with whole exome sequencing. Yeah. And they said that the microarray demonstrated copy number variants of around 20 regions of homozygosity, but they try a whole exome sequencing and secondary findings were negative.
Enzyme levels are high now, so
Yeah. So Raghavendra, I think he's on the chat. He's the father. So Raghavendra, any doubts you can just clarify in the chat. Yeah.
No, the galactoside cerebrosides
Hmm.
enzyme is very well high, and he has
Yeah.
got GLC.
Yeah. But the imaging doesn't match at all.
Imaging doesn't match at all. All the three scans don't match, is it?
No, it's the same. So there's a mention of he has pseudo Graves as the mother and kid to have the same genes.
Trio is negative, so mother and kids don't have the gene.
They have the same gene.
Dr. Raghavendra wants to speak. Dr. Nihaal?
Lakshman, just make Raghavendra the finalist. No, he's the father of the child.
Okay.
Okay, sir.
Yeah, Raghavendra, go ahead.
Done, sir. Thank you.
We did the same test for my wife and my other elder kid. They found the same genes that they are present in the second kid. The particular gene report you are seeing is for second kid, and they suspect it's because of the pseudo deficiency allele. Galc might be low, but in when you test the blood level, galc might show low, but it might be normal in the body. And my wife is around 30, she's normal, and my other kid is around 6, and she's also normal, and IQ level also very good. So that's why they still suspect Krabbe. Krabbe might be there, might not be there, but it's not impacting, and only they were concerned about the abnormalities we had in that brain pawn size and all. And the other thing is during the pregnancy, like my wife had a COVID, and at the 5th month anatomy, they found a prove the like a right umbilical persistent right umbilical vein. I'm not sure whether they caused anything because of COVID or this, but only the second kid have currently is kind of a 18-month. He's taking few steps since last week. Before that, he was not taking. He crawls all around the home. He can hear clearly. Blabberings not at kind of he screams and he gets our attention, but doesn't take any consonant words and all. That's his current status.
Just go back, Dr. Nihaal.
Yeah.
So, so the mother and the other child is carrying the same gene, correct? But here they're saying trio, including secondary findings, were negative. But if they're carrying the same gene, then it is not relevant.
Yeah.
Correct. And the DOC7 you found, that gene is not here, correct?
DOC7 particularly, that report doesn't talk about that. I have asked the doctor, did they test the DOC7? They haven't responded, but we did both whole genome and whole the other one. I'm not sure of that. Yeah, both genome and
LOX HD, both you and your wife are carrying it, so it's variant of unknown significance. SLCY2, mode of inheritance is unknown. So again, both of you are carrying it. So these two are not relevant.
Yeah.
So only relevant gene is the GALC, but you're saying that again, your wife is carrying it.
yeah. My wife is homozygous, my other kid is homozygous, I'm heterozygous.
Then it's not relevant then. Sometimes what happens is
sorry, yeah, go ahead, Doctor.
yeah, sometimes what happens is they do this, though they say they look for all the genes, they may not have actually looked into it. So if Dr. Nihaal feels that DOC7 fits in the MRI, then they can specifically look for it.
Yeah.
Yeah, I had shared the case with Dr. Bolthauser too, since he's an expert in post imaging. He was not very specific, but he had raised the possibility of DOC7 and also asked to look for renin pathway disorder. But renal pathway, I think the cerebellum usually hypoplastic and there's afolial appearance. But the DOG7 reference was sent by him, so which has at least the pontine shape morphology is similar. But the clinical picture is slightly different. I think they have epileptic encephalopathies and cortical visual impairment, if I'm not mistaken. Yeah, so infantile epileptic encephalopathies and cortical vision impairment. So child does not have epileptic encephalopathy, right, Raghendra?
No, he doesn't have that.
Yeah.
See,
So
and
only there
again,
was, yeah.
this is uniparental isodisomy. So that means you have to specifically look for it. You cannot see it on whole exome or whole genome.
Yeah, no, I understand. I'm just telling that imaging wise,
Yeah.
it might be a match, but there's some features in clinically which are not present at the moment, at least.
Okay. Yeah.
So they have advised to Raghavendra, what have they advised? Annual
They have
wellness-
they keep giving the physical therapy and occupational therapy and visit after 6 months. They maybe it's a positive target. They expect him to be normal by next 6 months and all.
Yeah.
That's all. Currently, after physical therapy, like at 9 months, he was not even crawling. We started around 9 months physical therapy, occupational therapy. He started crawling around 11 months. Till last week, he was not even walking. Now he's kind of taking around 10 steps independently. He is 17 and around 18 months. In another 1 week, he'll be 18 months.
It's good that he's making progress with his development. Again, that will go against Crabbe because they have regression of their development. So I think you should just continue with the physical therapy and occupational therapy and take it slow because if it's disomy, you will not get it on microarray or whole exome. You'll have to do a specific test for it. So.
Okay. Sure.
Yeah, Hina raises that DOG7 can manifest with myasthenia gravis, so myopathic features can fit. May have more or less girdle weakness with facial weakness. So I think the Arvind has already asked for DOG7 gene, so we will wait for a response if DOG7 is there or not.
Sure. Yeah. I think one thing is Krabbe, I might not be concerned because they found the same gene homozygous for my other kid and my wife also. And if it was Krabbe, like my wife is almost 30 and she is even from an IQ level also, she's doing in a scientific job and all. I don't think that's maybe because of the pseudo deficiency allele, they might find it as Krabbe. I think still research need to be done. Otherwise, we would have been in trouble, right? When my wife or other kid would have been struggling by this time. Probably this only the abnormalities and we don't present in the. We did the MRI for my wife and my other kid also. They don't have these abnormalities.
Yeah, definitely not Krabbe's on imaging. It's a malformation kind of abnormality. So I think 6 months checkup and annual checkup is sufficient for now, Raghavendra. Till they have a gene.
Yeah.
Because they
Thank you.
usually reanalyze the genes every year to look for any additional in the literature. So they keep on adding genes, if I'm not mistaken, to their exome.
Yeah.
So
Okay.
yeah. So if the child
Many
is
of the
improving,
structural
yeah.
Yeah, sorry.
Yeah, Dr. Please,
That's
sorry.
many of the structural abnormalities, there might be somatic mutations which will not be
Yeah.
picked up on the blood. So I think they wouldn't come up even if you repeat, but I think they will anyway reanalyze the sequencing again, as you said, every year. The child is improving gradually. There is nothing, it will keep improving. It's not a worsening process, at least in principle.
But can we confirm from these abnormalities it's a pontine hypoplasia and hypoplasia of corpusculosum or
Yes,
no?
yes,
It's
that is undeniable.
Yeah.
That fact is there. Yeah.
okay. So both are there and degree might be minor, might be major, right?
The degree of hypoplasia is, I mean, it is there, but I've seen all the 3 scans and it is not reducing, at least in comparison to the first scan. So it is remained the same. Usually the malformations, they remain the same. They usually don't progress or regress.
And the cerebellum is normal, right? Here.
Cerebellum is normal. Yeah, that's fine.
Okay.
So it is not technically a PCH spectrum. It's only a pontine hypoplasia and corpus callosum hypoplasia.
Okay.
Yeah.
Any experience from the past? Will the kid be able to speak and walk, or no? With this, it's very difficult for him to walk and speak.
Radiologically, I would not know, but maybe one of the neurologists can.
Lokesh, sir, any input here? Okay, thanks. Thanks a lot.
Yeah. All right. Thank you. I think we have Aarti, so we'll go on to her case. Aarti, if you're there,
Yes, sir.
over to you.
Yes. So this is an 11-year-old female who was admitted in September 2023 with history of intermittent fever for 4 months duration, productive cough for 2 weeks, and prior to this illness, she had traveled to Singapore in the month of May before the fever started, and that was at that time when she had fever. It was a very brief duration, treated as upper respiratory infection. Then the fever subsided and recurred in June month, and with vomiting, abdominal pain, and dehydration. So she was treated as leptospirosis outside. Fever persisted and developed. She developed productive cough, and there was a history of contact, but there was a remote contact TB, bone TB in mother treated 10 years back, and childhood pulmonary tuberculosis in father. So she was tested for the same. She had fever on admission with palatal petechiae, oral exanthem, and respiratory wise, she didn't have any much findings. But chest X-ray was normal at admission. Sputum gene expert was negative for TB, but the CT chest was showing consolidations and pulmonary nodules with ground glass opacities and mediastinal lymph nodes also. And her lymph node, she has an enlarged supraclavicular lymph node. So biopsy of that showed MTB in the gene expert. And it was rifampicin sensitive. So we have a...
Okay, I have 2 sets of imaging. Is this the first one in October?
Yes, sir. The reason for doing this was she was started on ATP in the month of September, and for this fever and cough, she had already had a mediastinal and a lymph node involvement. So the reason for this is she had intermittent headache with infrequent vomiting. So we did an imaging. And papilledema was there.
All right, thank you. So on top we have diffusion, some areas of paradoxic edematous changes in the left parietal region out here, the right frontal lobe out there, associated cystic changes, better appreciated on the flare sequences, significant perilesional edema. You can see the frontal lobe, the left occipital lobe, the posterior lobe, the brainstem structures, the mammillary bodies on both sides, the basifrontal regions, and also the internal capsules and the external capsules on the right side. There is some mark effect on the anterior aspect of the corpus callosum along the right side. T2-weighted sequences, again, multifocal lesions, predominantly T2 hypointense to isointense mixed intensities, going likely granuloma formations out there with significant perilesional edema. On the SW sequences, could not appreciate any areas of significant blooming corresponding to the lesions. And based on that, I think TB was the consideration.
Yes.
Yeah, on ATT. Yeah, go ahead.
So the 1 month later, that is when she came with headache and vomiting with meningeal signs and papilledema. This MRI which was shown was done, and so she was started on steroids, followed by steroids along with the ATT. Initial time when the ATT was started, steroids were not given, and she was given total of 8 weeks of steroids, and within that time itself, the steroids were tapered and stopped. And after 2 months of intensive phase with Reddy, there was ethambutol was also stopped by the treating pediatrician. There was resolution of papilledema and there was no optic neuritis. But she came in the month of January with occasional backache and headache, with increasing frequency of headache. And that time steroids were restarted at full dose of 2 mg per kg, and then followed by she was readmitted in the month of November itself with this headache and increasing episodes of back pain. So that time steroids were restarted, and from that time she was asymptomatic. Basically, she did not have any major deficits, but there was intermittent headache with back pain. But with steroids, it was actually clinically she was improving whenever she was coming with this thing, with the acute episodes of headache. But examination wise, she had a right eye field defect in the form of inferior quadrant anopia, and left eye also medial field of vision was restricted. So second MRI was done when she came in the month of March. That is almost 7 months after the ATT was started.
This labs are after the MRI or before the MRI?
Labs are during the second admission in the month.
Okay, all right. We'll get back to that. Yeah, so the second MRI, I have flare stat sequences out here, or T1 flare. So you can appreciate again the lesions in the frontal lobes, the parietal lobes. Post contrast, I think we didn't have a contrast in the prior study, but post contrast, again, you have these peripheral not enhancing lesions, some conglomerated lesions in the left parietal lobe. Could not appreciate significant meningeal enhancement, possibly along the parts, but I don't think that's significant. So other than the lesions in the parenchyma, at least on these imaging, cannot appreciate any significant meningeal enhancement. I think ASL was done and a spectroscopy was done. It is showing reduced perfusion, and the spectroscopy is typically characteristic of a tuberculoma out here, elevated lipid peaks. So the question now is, what was the question, Aarti? Is it iris-related TB or is it drug-resistant TB?
Yes, sir, that is the
Or-
question. Because even now she has been discharged on steroids only. Like we gave her an increasing dose of steroids parenterally. After that, there is a resolution of headache. Actually, we have suggested the biopsy of the lesion, but the parents had denied it. So radiologically, whether we can take it as iris or is it drug-resistant TB, should we go ahead to escalate with other second-line drugs after doing a biopsy and sending that for rifampicin sensitivity and gene export?
Okay, I'll open the case for the panelists. Was the LP repeated from Jan before we come to the discussion?
LP could not be done, sir. LP could not be
Okay,
done.
okay.
She had very increased ICP.
All right. I think Sridhar has mentioned the initial imaging itself looks like disseminated TB or like TB iris.
Yes.
Immunocompromised status,
No, HIV negative. HIV status negative.
but I think the interval scans it has not increased as we don't have a contrast study. Usually the TB iris they usually progress in some form of imaging features, but the initial scan itself is so extensive and disseminated that itself could be a TB iris manifestation.
So some of the lesions have become more conglomerate, and some of them like looking like abscess, and granuloma is becoming more organized. So these well-organized lesions may not be very easily treatable by is it required that we have to think of drug resistance, or we just radiologically are there any clues to say that it is iris only or drug resistant TB? That is the point for discussion.
Is there a criteria clinically for drug resistant? What is the response time or?
Usually when the child is not improving at the end of intensive phase and
Okay. So at least this is the criteria they take for TB iris. Whether they fits the criteria, you can just check any new or worsening TB meningitis features, new or worsening space-occupying lesions like tuberculomas. Our child has tuberculomas. A spine wasn't done, so that we are not sure. Recurrent headaches could be a clue, I guess. I think Sridhar also has mentioned that. Worsening MRIs, I'm not sure, Sridhar. We need to evaluate this contrast for both. But yeah, Dr. Habib says the paradoxical reaction, most likely wait for response. Or like Dr. Sayani says, clinically have to differentiate between both, but picture fits into iris more. Sridhar has mentioned that fevers are improved and is less likely drug resistant. TB iris has more neuroinflammation without fevers. The question from Jayashree, was the child a bit better before the new onset of symptoms? I think that was what was
actually
mentioned.
She had a prolonged fever which stopped occurring after the starting of ATT, but only after the CNS symptoms and after the evaluation for that was done, steroids were started. She is systemically well. She's still able to be. She's self-ambulant and not having any major deficits except for the field deficit. Headache has improved, but since they denied for biopsy, we could not go ahead with it. So was a biopsy required mandatory at this point, or we have actually not been able to do because of parents' denial for the biopsy of lesion.
Any diffusion changes on the second? I don't have diffusion sequences or T2s.
CD4 T cell count can help.
Okay, ma'am.
Can it have you done CD4 T cell?
No, ma'am. CD4 we have not done.
And I think Dr. Sridhar Datta has mentioned, Dr. Sridhar has mentioned something about TNF alpha also.
In terms of size of the lesions, I think Aarti, I think there are some increase in the size of the lesions. Because we don't have a contrast in the first time, but you can see that these nodules are, I mean, these lesions are slightly smaller than compared to the follow-up scan. But again, difficult to say. I don't have T2 sequences again. But on the flare, you can appreciate there is some increase there. I think Dr. Jayashree says IDS should present within 3 months of initiation. This was after 7 months, if I'm not mistaken. Biopsy is not required. Amina says posterior corpus callosum is drooping. It is drooping. Can be seen in developmental delayed children too. Amylopontine angle. I cannot measure the angle, but I don't think there are any features of potential.
So one of the panelists has mentioned the prolonged course of steroids, but now she's on steroids for the last 2 months. That is like second course has been started and she's still at 1.5 mg per kg per day. So if we have to bring her out of steroids, then should we test for drug-resistant TB so that we can start with second-line drugs? Or is it okay to wait and repeat an imaging later on? Madam, CD4 count, how does it help at this stage, madam?
CD4 count is apparently a lot elevated in children with TB iris compared to other compared to the general TB population. I can post a paper for you if you want on the
okay,
group.
Sure.
I'll post
Okay.
it on the Neuroradiology group.
Sure.
They're also saying, just like Dr. Sridhar said, TNF alpha levels. These can also help in differentiating. I mean, you have to. It's like a pieces of puzzle, na? You put everything together and then decide which way you want to go. You want to go with immunosuppression or whether you want to, persist with the TB treatment.
Okay.
All right, the suggestion of you can taper them after every 2 to 4 weeks, after 2 to 4 weeks, and maintain dose for 3 months. To start thalidomide if it's not started yet.
Okay.
Yeah, I agree, Sridhar. Repeat imaging only if there's clinical worsening, because these enhancement patterns can be seen up to years in TB. So that is not a marker of the active inflammation or progression.
Okay.
But if there's clinical worsening, you can get a scan done.
Sure, sir. Okay.
Yeah.
Thank you, sir. Thank you.
All right. Thanks, Aarti. All right, to the next case, Anas, if you're there.
Hello, sir.
Yeah.
So, this is a 14.5-year-old female child. She's a known case of chronic ITP. So now she had fever for 2 weeks, influenza pneumonia, which settled down. 1 week after the pneumonia, she had pain abdomen with bilious vomiting, which was there for 5 days. On 6th day of this illness, she had right focal seizures in the form of clonic movements, and then she had some generalized seizures as well, for which she was admitted. In view of recurrent seizures, she was started on anti-seizure medications, which the EEG showed continuous NCSC, for which she was kept on IV midazolam and IV ketamine. And they also suspected autoimmune etiology and started on immunomodulators in the form of IVIG and IV methylprednisolone. So from these symptoms started on March 8 and till the end of March 21, she was still on mechanical ventilator, requiring ketamine, thiopentol. Her seizures started to decrease from 22nd of March.
Okay. So, Unless
after
wait,
giving autism, but again once start to increase. Now she's currently mechanical ventilator, trachea system is done, and E1, V1, M1. Family members had come with MRIs and this history and wanted to know further course of action and what is the possible diagnosis. They have sent some investigation. Should I say the
okay.
investigation
So
now, sir? Or?
no, we'll go sequentially. I don't have the
Sure.
main scans. I mean, they're slightly degraded images, but let's see. March 8th MRI. I think this is diffusion. Cannot appreciate any area.
This is the onset of
Yeah.
neurological symptoms when she was.
Yeah. Okay, so diffusion, I think not able to appreciate any significant abnormalities out here. On the T2s, there is some degree of volume loss, supra and infratemporal volume loss. Cannot appreciate any focal lesions. I don't have an axial. Again, coronal sequences. Again, there is some degree of volume loss in the supra and infratemporal brain parenchyma, more along the cerebral hemispheres on both sides. Angio was done. I'm not sure why angio was done, but on angio, at least these MUP images, I'm not able to appreciate any focal narrowing, stenosis, thrombosis, or any abnormalities in the intracranial arteries. 2 days later, we have the flare sequences out here, and you can appreciate subcortical cortical edematous changes, confluent edematous changes in the bilateral hemispheres, more along the frontal and parietal lobe. I think some degree of edema also in the inferior cerebral hemispheres on both sides. The cerebellum is involved, the subcortical cortical lesions are involved, predominantly in the frontal and parietal lobes. Diffusion again, cannot appreciate any corresponding changes. Yeah, there is some focus over here in the right posterior thalamic nuclei. There is some area of restricted diffusion out there. Was there any seizures, Anand, in between? March 8 to 10?
Yes, sir, yes. She was on continuous seizure. She had continuous seizure activity.
All right. Okay. So that might explain ictal changes. But other than that, the edematous changes predominantly demonstrate facilitated diffusion. As you can see on the ADC sequences, they are bright. So again, flare sequences, you can appreciate similar abnormalities which are seen on the T2s. Again, confluent abnormalities predominantly involving the peripheral regions of the brain and predominant involvement in the frontal and parietal lobes. Some deep brain nuclei involvement is also seen. On the diffusion, again, we don't see any significant changes. Again, there's, okay, I think this is a scan later on. Is that right, Anas? Because over here, there are fresh changes in the left hippocampus, which was not there in the previous study. All right, so left hippocampal cytotoxic edematous changes and these confluent abnormalities in the bilateral hemispheres. In between, what is the clinical presentation, Anas, from 10 to 27?
Yeah. So she attained burst suppression with anti-seizure medication. Around March 17, she regained sensorium, but she was not back to baseline. By March 22, 28, there was some improvement in alertness, but she was still mechanical ventilated. Meanwhile, they were working up for autoimmune and vasculitic etiology. But there's no improvement in her overall this thing, but she seizures controlled.
All right, I think the suspicion was of CNS vasculitis. I don't have contrast sequences. I don't have SWA sequences, which could have been possibly helpful to look at microangiopathies and contrast enhancement. So these are the typical features of CNS vasculitis. They can be confluent abnormalities, especially this imaging pictures is similar to our child, but we don't have other ancillary sequences to confirm the possibility. In the case of ITP, I thought probably press also can present with these changes as one of the contributors for the imaging findings. Then the lab follow-up was done, workup was done. So Anas, you can directly highlight us what was the findings, main findings. Yeah.
So initial suspicion based on the mild behavioral changes and focal seizures initially was autoimmune by the team. The autoimmune panel done there was negative. They had done vasculitis in view of the press-like changes. They had done the vasculitis workup as well. The P ANCA, C ANCA, ANA were negative. The initial pain abdomen and later the abdomen distension, I think forced them to think in line of like systemic vasculitis, and for that CT aortogram was done, which showed partial thrombus and diffuse edematous circumferential wall thinning the colon and rectum. Maybe IBD or infective colitis was other suspicion what they have.
Okay, so we're thinking vasculitis, thinking demyelination, as Sridhar has mentioned, one of the differentials. So I'll open the case if anyone has any further suggestions.
Out of interest, how many anti-seizure drugs you're on and which anti-seizure drugs you're on?
I mean, the child is not with us, but she was started on ketamine, thiopentol, midazolam infusion. Current is the medications we don't.
Current? You don't know the medications?
Yes, ma'am. But she has received IVIG, ITP for IVIG, IV methylprednisolone, and 2 doses of bortezomib. They had come more for the etiological this thing. She's being managed elsewhere.
Oh, she's being managed elsewhere. Okay. Bortezomib. Is that the JAK inhibitor, sir? Bortezomib.
Yes.
Any elevated BP, I mean, blood pressure markers, hypertension, sorry, in between or checked or not checked?
No hypertension.
But still, ITP is I think a risk factor for stress-related changes.
Dr. Sridhar has suggested MOG antibodies. That's not
Yeah, I'm checking with
He's saying bortezomib is a proteasome inhibitor, not JAK.
Only thing is press the changes of progressed in comparison to the first scan in the 2-week to 3-week period. That is slightly atypical, I think, for only press rated changes. Any renal involvement, Hans, from Roman?
Not that we know of, at least nothing in the CT scan to suggest, or clinically as well.
Kavjot asked systemic aneurysm. Systemic aneurysm. CT aortogram was done. See what was that? Nothing on the aortogram, but changes of pneumonia, sphenomegaly with an infarct was there, and thrombosis and ischemic wall changes of the rectum. Spleen size from Dr. Koshin. Anas, I think spleen was not mentioned. The size was not mentioned.
Not mentioned.
And bone marrow.
They have not done bone marrow that I know of. We can just get that information.
Question of the Prabjot says systemic vasculitis to be considered. Dr. Kalpana asked, was there any hypotension or cardiac arrest in between?
She was an inotropic support temporarily, but no cardiac arrest or anything as such.
Dr. Namata suggests the HLH workup to be done.
Okay, sure.
For now, Dr. Sridhar suggests interleukin inhibitors can be helpful. So I think HLH workup and inflammatory workup to be done. Anas, that is what that are the main suggestions from this case.
Yeah. Any need of any further imaging other than this thing?
I mean, a complete imaging would be helpful. All the sequences with contrast, vessel wall imaging.
Vessel wall imaging. Okay. Sure, I'll share with the team.
Yeah.
Thanks.
Okay, thank you.
So, again, PRES is the chronicity of the changes. So likely some vascular.
Initially press okay, but this progression after at least 2 weeks. That should not be the case for breast.
Thank you.
But we need a whole set of sequences to evaluate properly this.
Okay.
Especially SWA contrast. Yeah?
Take it. Thank you.
And systemic vasculitis workup and HLH workup, as Dr. Namrata and Dr. Poshan has mentioned.
Thank you. That's helpful. Thank you.
Yeah. All right. Okay, that concludes our new cases. We have, I think, 3 follow-up cases with some diagnosis and some follow-up imaging. Okay, before that, Hina asked, will vessel wall imaging show anything if MRI is normal? Firstly, we'll have to look for any new infarcts. Then we can do a vessel wall imaging. Otherwise, you can usually see the flowoids on T2s and flares, and you can see the circumference of the flowoids. If they are demonstrating any hyperintensities, then you can go with the vessel wall. Yeah, if MRI is normal, still I think vessel wall imaging is more specific rather than MRI, because usually MRIs are time of flight images, not contrast images. Okay. Anas, if you're there, you want to quickly go through this case, yeah.
Quickly tell the background. So she's a 12-year-old female child born to third-degree consanguineous parents. She was development file till 3.5 years of age when she had febrile onset seizures. Initially febrile, then afebrile. They were of different polymorphic semiology: focal motor, focal occipital seizures, and GTCS, gyratory seizures. These were the initial complaints. In the past 1 year, she had balance and memory issues. The past 2 months, these were worsening, balance and memory, for which she had come to us. During that time, we had gotten the initial MRI. Prior to that, MRI was normal, which was discussed in the prior neurology meet. There, the suspicion. So this is the.
Do you want me to show the MRI? Yeah, I'll show the MRI first. Okay.
Right.
So MRI, the main changes were in the central regions. Again, you have these hyperintensities in the central median thalamic nuclei on both sides. And the inferior collicles of the midbrain tegmentum demonstrated these periaqueductal changes, hyperintensities. Other than that, we could not appreciate any significant findings. Basal ganglia was relatively normal. No other areas of focal abnormalities, no malformations. So these were the main findings, which did not corroborate any changes on the diffusion or the established sequences. There was some degree of Vermeer atrophy, but other than that, the main changes were along the periependymal regions or on the lateral ventricle, or the third ventricle, and the periaqueductal region. Spectroscopy was done, but I think, as you can see, it is not optimal. There are multiple artifacts. It is not, the x-axis is not clearly defined. So spectroscopy did not help here. Then I think the whole exome was done. Am I not mistaken, Anas? Or before the initial report which you got back?
But we had drawn blank. But when she presented to us, she had headache, vomiting. During the acute period, we had done blood lactate. It was high 4.8. So the MRI finding along with the lactate prompted us to think in direction of mitochondrial, but our whole exome whole exome sequencing and even mitochondrial genome was negative. So last time what inputs we got is still it could be under the mitochondrial spectrum to work on that line. So we had followed up the child. Meanwhile, we got reanalysis done. We don't have the formal report, but the lab has told us that this TEFM homozygous mutation is found in this child. So interval changes from the last time, her cerebellar signs are better, but seizures are still there. Gyratory seizures are still persisting, and we have this. We have a genetic answer. Have to wait for the formal report, but this is the tentative report what the given to us.
All right, thanks, Anas. If anyone has similar experiences with the same gene or mitochondrial disorders predominantly involving the periaqueductal regions, brainstem. Okay, I don't think you have any experience with TEFM gene, but the imaging findings I discussed initially had a suspicion of a mitochondrial disorder. So yeah, this is what has come out. All right, if there's no further, I mean, if nothing, no one has further experience. We'll go on to our next case. So thanks, Anas, for the update. I've added one more case. If you can just stay on for another 5 to 10 minutes. So anyone from Bharati Vidyapeeth is there? Krishna Priya, Dr. Kavita. Okay, I don't think they're there. So maybe we'll skip this and do it up for the next session. Unless if you're there, just want to highlight, update this child. Scan was done today, so I just want to have a comparative.
Yes.
Yeah, you can quickly go through the findings.
Yeah.
The clinical presentation.
Yes. So he's a 4-year kid now. He presented to us at 1 year of age with initially left-sided proptosis and then right-side proptosis with restriction of movement of eye. He was managed on OP basis. We had advised admission, but the new financial constraint, they took OP basis IV antibiotics and had gone. Symptoms had resolved. Now 3 years later, he again presented with similar complaints and headache, vomiting, irritability, and restriction of eye movements, and worsening visual acuity, for which he was admitted. Initially, we were thinking in lines of LCH or a lymphoma. So we had done a biopsy of the bone. Unfortunately, tissue could not be taken. Biopsy was taken, and it was initially not proven conclusively, but suspicion of few histocytes were seen. So we started LCH management, but there was no improvement. Then we got a repeat scan after that, which led us to believe in line of fungal, and child is being treated in the same line with IV fungal antifungals. And there's interval improvement in symptoms, vision, headache, things are better. Repeat scan, I think sir will discuss now. And we have gotten genetic report as well, whole exome, and that is negative. So we don't have any answer in that front. But yeah, he's improving clinically. Lab wise, we have beta glucan and galactomannan positive. We have taken an ID consult, and they are also thinking in the same line. We are not sure if we should still consider chronic granulomatous disease, although genetics are negative, but if peripheral markers like NBT or DHR will help in this case or not.
Yeah, just to update, the scan was done today, a follow-up scan. Child is on antifungal, as mentioned. His soft tissue abnormalities have reduced in comparison to the prior scan. As you can see over here, the inflammation has reduced. Even the extracorneal abnormality, the thickening of the rectus muscles, in comparison, is reduced. This was around 4 millimeters now. I don't have the measurement. But even the massticator space abnormalities, in terms of the inflammatory changes, have reduced. The only thing was the cavernous sinus. There was mild interval progression, so around 1 millimeter to 2 millimeters. The child also had, I think, recently presented with thickening of palsy on the right side. So only the cavernous sinus abnormality is slightly progressed in comparison to the other abnormalities, which have significantly reduced. Even the paranasal sinus inflammation, which was there on the prior study, is not seen on the scan. We didn't have a contrast on the prior study, but this is the scan with contrast for today's scan. As you can appreciate, there is dural enhancement, cavernous sinus infiltration, and also this orbital extension out there. So yeah, we're treating it as a primary fungal infection, but wanted to know if there are any other possibilities to be considered.
I think last time we got input at IgG4.
Yeah, IgG4, yeah. But that is usually a diagnosis of exclusion. Dr. Rani, sorry, we couldn't hear you.
Sorry, I just no, I just want to find out is what immunodeficiency workup is negative.
We had sent immunoglobulin, whole subset we had offered them, but which was not done because we thought we'll get the whole. Hello?
Yeah,
go ahead, Anas.
Yeah. So yeah, we had sent IgG levels, which were normal, immunoglobulin level. Subset we had offered them, but they wanted to wait for the whole for the genetic report, and then we have not sent because we have two tests.
You're in a competent child, right?
Yes. Otherwise, he was thriving well, no other issues. He had this issue at 1 year of his first birthday when he had this symptom. We had offered him this PID workup, they had not done. Now, when they presented, we were working in line of LCH and lymphoma. Only when the symptoms worsened after the LCH management, we started thinking of fungal. At the time, again, when we had offered, they wanted to, we had sent the whole exome, so we were waiting for whole exome. Subset analysis, we have not sent. DHR, NBT, all these things we have not sent yet.
DHR has been sent today. DHR and NBT.
Okay, the suggestion of Tolosan syndrome, Rosai Hoffman, I think that has come negative, if I'm not mistaken. Okay. So we are planning for another follow-up, maybe a couple of months later, 4 to 6 weeks later. We'll get back to you with the imaging.
Symptoms are improving in the form of swallowing, headache, vomiting, overall irritability, vision. Initially, it was completely absent. Now, near vision has improved. Far vision, he's able to count fingers. But there's still some restriction of eye movement on the right side. More towards the lateral rectus side. There's some deficits, but overall, there's improvement. We have taken ID into the team, and they've suggested to continue IV antifungals for now, and after 2 weeks we'll reassess.
Anju, is Arunabh still there?
Sorry.
No, I think that wasn't fair. Yeah, Apnidi says Tolosa Hunt is a diagnosis of exclusion. I agree. Okay. Yeah, the only thing is fungal has come positive. That was the only thing. So if all negative, do we ignore the fungal thing and the improvement on the fungal medication?
There's one fungal specific PCR. There's a lot of fungi over there. Can the tissue be sent for that?
Actually, we had
Tissue. Yeah, go ahead, Jonas.
Yeah. So we had discussed the oncology team because they usually send lots of biopsy from that area for other things. So they said there's a possibility we can do, ultrasound guided from the orbital side. We can go ahead and try to get. We have explored that possibility, but we are not sure if the child is improving. Should we go for another invasive because child has already undergone one biopsy? But that is an option we were keeping open. We can get a tissue if required. If that's the...
Yeah, and there's no point in doing it if now it's getting better.
Yeah, and the tissue, this one, mass also is getting better significantly, isn't it, Nihaal? The soft
Yeah,
tissue swelling. Yeah.
And the sinuses were clear, right? There was no
Yeah, the
sinus.
sinuses are clear now. Yeah.
So before they were also clear or not really?
Before there was some inflammation, as you can see over here. Yeah, before you can see that there is some thickening there, ethmoidal sphenoid. So in comparison to that, it has, now it's almost clear in today's scan.
We had asked our ENT team if any wash would help or any sign. They said ki yield will be very low. That was the discussion at that time. If any biopsy can be taken or any tissue biopsy or tissue specimen can be done from the sinuses.
Yeah, but the sinuses are clear now. Relatively clear, so I don't know if it will be helpful. Yeah, okay. If there are no further comments, I think That is our last case. Okay, Dr. Nikhil mentions does not seem to have sinus in origin. There is very minimal sinus involvement. Yeah, I agree.
Yeah, we got a ENT consult as well. They said there is nothing much we can do. A biopsy, whether get more information. That's what they said in the beginning as well.
Okay, so that was the last case. I think we'll conclude our session. Next session will be in 2 weeks' time. Request you to send in your cases. All are welcome to send their cases. You can contact me on the email or you can join our WhatsApp group.